We are going to start with our track 2 on modernizing healthcare. Modernizing healthcare is a journey towards re-envisioning healthcare to serve us better. Therefore, healthcare providers must innovate to transform healthcare delivery models to provide better experiences.
May I request the chair and the speakers of the track to kindly come onto the stage, please. Colonel Binu Sharma, founding member ANEI. A round of applause for Madam. Ms. Srilata Shivalenka, senior consultant UNICEF. Round of applause, please, ladies and gentlemen.
Ms. Tankam Gomez, former national president ANEI. Can we have you on the stage, ma'am?
Ms. Patricia Mary, nursing superintendent, MS Ramaya Memorial Hospital, Bangalore.
Ms. Bindu George, chief nursing officer at AIG Hospitals, Gachibowli.
Dr. Rajni Peter, professor and principal, College of Nursing, AIIMS, Nagpur.
Let me take this opportunity to introduce our chair for the session on modernizing healthcare. Colonel Binu Sharma, founding member ANEI, Senior Director Nursing, Max Healthcare. Ma'am has more than 4 decades of rich experience in nursing profession. She is an ex-graduate from Armed Forces Medical Services. She has many accolades: Women of Excellence Award, India's Achievers Forum 2022, Nightingale Award for Nursing Leadership, Mother Teresa Memorial National Award 2021, and many more to her credits. She is a renowned author of some phenomenal books, publications in national and international journals. She is the president of INS India, certified NABH and Nursing Excellence Assessor. We are very much privileged to have you this morning. Share the session, ma'am.
Thank you. A very warm good morning. Namaskar everyone at AIG, a beautiful auditorium, and I have the proud privilege to start with the first scientific agenda. What a beautiful topic, modernizing healthcare. Are we modernizing healthcare without modernizing nursing? I don't think so. I'm remembering a quote. Sometime back I read a book, "What got you here will not get you there." So my dear nursing leaders and the practicing nurses in this room, what got us here in the 2020s will not take us forward if we were to become the future of the healthcare and the, the theme, our nurse is our future. So with that, I take the privilege of having esteemed members on the dais who are going to discuss the topic. We have Ms. Srilata Shivalenka, who is the UNICEF senior consultant with UNICEF. And as you see her profile, you see so many credits to her power. She is South India Program Manager, Director and Faculty at Institute of Health Systems, Research Officer. She also has a lot of award and accolades to her credit: the Path Global Award, International CDC Award for Exemplary Services in HIV and AIDS, recipient of several United States Mission Honor Award, and we can go on and on for her. She also is a member of Joint Implementation Review Committee at World Bank for NACO. She has led multiple research projects. I think we don't have a better person talking to us today if we were to have the future of nursing getting defined. Just to set the context for the topic, as I said, what got us here will not take us forward. Nursing has been traditionally run, although there have been so many advancements in the field of nursing. Even in India, we are scaling up with corporate nursing, we are scaling up in technology, we are doing wonders with simulation labs and simulation-based trainings coming up. But we are still very, very, very in a traditional zone. And if we were to be part of the scaling up of healthcare, we have to change our approach. We have to come out of these silos. A favorite topic of Ms. Sangam, that we need to get out of our comfort zone. Many of our nursing friends have a discomfort in coming out of the roles they do, the traditional roles they do. So we have to break the barriers. We have to adopt technology at the pace it is growing in our country and globally. There are so many efficient methods of improving our time management, the remote monitoring systems, the patient bedside based documentation on smart devices, and efficiency in every single manner. We have to open our mind to change the way we have been functioning. We have to get out of the nursing narrow bandwidth to become part of the larger team, intermediate teams, interdepartmental teams. Nursing leaders are already heading operations. They are heading many other fields in the hospital. But that number is highly minuscule. Most of us like to just stay in the vertical. And hence, we need to open our minds to have a newer approach to change the face of evolving nursing in the country, hence become part of modernization in nursing and contributing to modernization in healthcare, which is the theme for today's times. With that, let me invite our first speaker, and that is Ms. Shrilata, sorry, my apologies. Ms. Shrilata, over to you for your presentation.
A very good morning to all of you, and thank you very much, the chairperson, Colonel Binu Sharma ji. I think it's a great privilege for me to be here this morning. I don't know whether I'm the right person, but I feel I'm really fortunate because somebody else is supposed to be in my place. In fact, so I really feel that God has given me this wonderful opportunity to speak to you all. So definitely dignitaries on the dais, off the dais, my teachers and mentors and friends and all the students, I think I'm really, really privileged and humbled to be with you all this morning. I'm sure I'm just going to share my experiences. I know many of you are much more experienced. I know many of, I think I also have my teachers. I'm definitely not a person who would actually preach anything but I'll just share my experiences, and then definitely I would think that this is a forum for us to come together and then move forward and see that we have all the power, work together and see that nursing is always shining. To start with, I will not take much time, but there are certain slides which I want to share with you as we move on. So the topic given to me is future of nursing in India. And here's a disclaimer: whatever I'm speaking are my personal views, and and I would like to say that nothing is related to my organization or the employer where I work. So I would like to salute all the nurses. I need not read, but definitely I would like to, especially after the COVID, the amount of respect which has increased, globally on nurses. I think it's remarkable. I think people have seen what nurses are. So they are almost like angels who have given rebirth, for many of the patients. So definitely, I think COVID has reminded how nursing is so important. So I would like to salute all the nurses who have extensively contributed, given their lives away to save lives of others. So I think this is a very prestigious moment for us to celebrate and also thank them. Course, I'm from UNICEF. UNICEF basically works for every child, and I don't want to read the mission. I think most of you all know about it. It's mandated for us to protect the children. That is actually the most important mission of UNICEF. I think this is the tagline which I really like. I think it is also relevant for many of us. We never give up. I think we should all never give up. I think this will also apply for all of us. I would just divide the topic into 4 questions. Basically, I would say, what is the current situation of nursing? And our future is dependent on what? What is that we are looking, and what is that we have so far? And then the future of nursing in India. And then, of course, where are the nurse leaders, in the entire gamut of what we are talking about today? So in terms of current situation, there are definitely a lot of good news for us. Things are moving. We are moving, to the better place, I would say. 75% of the workforce in healthcare in India is, are nurses, basically. So you can see the power. So what happens, the 75% has a problem. The entire health systems will fall, right? So that's the power of nurses in India. So don't think we are powerless. We are 75% of the health workforce. So that's the best part of the entire profession. Okay. The second thing is the government is also recognizing that there's a lot of, it's very important that nursing is, a very important arm of the healthcare system. So with almost the 12th plan, 3,200 crores have been allotted. We are also proud that India is one of the major exporter of nurses. If the quality of nursing is not good, why would they recruit you? If you see, I think nurses are there almost in every country in the world. And we are really proud, not many, not few numbers, but a lot of numbers. And we'll see as we move on. So definitely India, we all should feel proud. Our friends, our sisters, all of us are there in different countries and they're ruling, they're leaders. It's not just they're working. So it's a proud moment for all of us that, we are supplying beautiful nurses who are really talented and professionally very strong to various other countries. So the other good news is again, the nursing education. Things are improving. Definitely in the 2017, we have a national health policy. A special mention is made about the nursing, the nursing education, how to improve nursing education in the country. We have PhD nursing now. We have revised the BSc nursing syllabus. Then we have national reference simulation labs, which were not there. So things are improving. So digital monitoring systems are available, nurse practitioner residency programs. Then we have the nurse practitioner primary healthcare program. And then, of course, midwifery, where UNICEF is also extensively involved. Especially in Hyderabad, we are also associated with Fernandez Hospital, where the midwifery 18-month program is also implemented. So, and then the centers of excellence. So we are moving, we are rising, and definitely all good news for all of us. So things are moving, and you can also see the growth of the nursing institutions. The bar itself clearly tells that, the nursing institutions are growing. And then, there is again the quality part is also being taken care of. So the other things is, of course, the ICN brand leadership program for the, is also been introduced. There is another program, the Global Health Program, Global Nursing Leadership Program by Harvard, which is mostly free for the third world countries. So I think we should also explore certain options which are available. Then we have the learning management system now. Then we have live registration system. I'll tell you the story, how we also started, where it all started. First, capacity building. So I think conferences like these are also very, very helpful for us to increase the knowledge. Then, of course, there are definitely a lot of concerns and challenges as we move on, because wherever, for any profession, not just for us and not for just for India, these are all global issues as well. But definitely we need to, in order to move forward, it's always good to understand where we stand. So the slide itself is self-explanatory. We do have shortage of nurses. Almost 2 million nurses, shortages always is there. Then we also have staff positions vacant. And these are big bubbles, not small bubbles. The current Indian nursing force is not sufficient to meet the sustainable development goals. That means we need more nurses in order to attain sustainable goals. Again, without nurses, definitely will not be able to achieve sustainable development goals for India. So, and then challenges in terms of quality, inadequate skill training. Again, the quality of nursing training, I think we need to address. Definitely, there are a lot of issues. I'm not talking about specific private public sector, because there are no teachers. So if you garbage in, garbage out. So what we are doing, if the quality is bad at the pre-service, definitely the quality is bad, the other end. So it is like, if the input is bad, definitely your output is going to be bad. So I think there are a lot of, that's why if you see the reports, whatever assessments have been done, a lot of suggestions were given at the nursing education level. If you don't improve nursing education, the output will definitely be affected. And then, of course, other challenges, we have limited career options, low employability, unattractive salaries in private sectors, high rate of attrition, migration, of course, is a problem. All the good, cream, intelligent, enthusiastic, I would say, but people are moving out. There are still very beautiful nurses over here who are actually facing all these challenges. So let us look at some of the data, what it is informing us. So definitely, if you see the rate of growth of institutions in India, initially in in 2000 and 2005-10, if you see the growth there was a growth spurt. After that, the rate of increase in institutions have come down relatively. That means, again, we have to rethink how many nurses we require, how many institutions are required, how the quality can be improved. So definitely the rate of institutions are going down. And the second part, what it talks about is the state-wise number of registered nurses. So certain states have huge number of nurses. For example, Tamil Nadu. There are certain states where you have, 1,000, only 1,000 got registered. But again, if I'm registering in Tamil Nadu, does it mean that I'm working in Tamil Nadu? You don't know. I'm not. So I'm registered in Kerala, but I'm working somewhere else. So data is so important for us, and that data is missing in the entire, profession. Then, of course, we do have statistics from INC, that's the only place. But again, we have large number of GNM institutions, which is, there in the, mentioned in the table. Then again, there is uneven distribution. Almost 74% of the schools are in only 10 states in India. What is happening with the other states? For example, in Northeast, you hardly find any nursing schools. So I think we have to think about the redistribution. So if only 10 states have 75% of the schools, then what is happening to the entire country? Is there equity? So we need to think about the distribution. We have to redistribute the nursing institutions in the country. Again, nursing institutions, almost 87% are in private sector and only 12% in public sector. Private sector nursing costs and public sector is free. So definitely we have to advocate for more number of public institutions in the country. And the quality issues, how much control we have on the private sector education. Not all schools are up to the mark. So definitely regulation of private sector is also an issue which we need to address. The number of institutions was registered, I already mentioned about it. If you see the registration wise, southern states have huge registrations for nursing, but how many of them are actually working in the respective states? Okay, so that needs to be looked into. Of course, there are a lot of news items talking about India to need 4.3 million nurses. There again, definitely there's rise in demand for India, trained nurses after the pandemic. As I mentioned, COVID has given us much more power. And also, I would say people have recognized what is nursing. So, okay. So we'll move to the next topic, that is this future of nursing is dependent on what? Social determinants of health. We cannot do anything alone. Definitely social determinants of health are very, very important. So it is, as WHO mentioned, we cannot ignore this. We have to, in order to reduce inequities, definitely we all as nurses have to consider the social determinants of health. I'll not go into it because most of you all know about it. Which is all self-explanatory: socioeconomic position, poverty, if I'm poor, my nutrition status is very poor, if I'm malnourished, how much nursing I would give to a malnourished child without giving food, right? So the social determinants, the socioeconomic status, a lot of other things are important for me to thrive. It's not just nursing, which is with nursing, I cannot improve the entire community's health, right? So all these need to be considered as we are moving forward. Workforce, again, the number of, the type and the distribution of nursing workforce, definitely we need to consider, the workforce that effectively provides the health and healthcare services in the society there is substantial increase in the numbers types. So I think nurse workforce is again very, very important. The education system, again, the education system that better prepares nurses for practicing. Again, the quality. Now, what is happening is the quality of education is poor. So when they join the service, again, the hospitals have to train them for 1 year. So if that happens at the pre-service education, then, the training which you are giving in the hospital can be avoided. So I think the foundation needs to be very, very strong for us. Okay. So these are, evidence is very, very important as we move on. As we move on, we just have to also see the burden of disease in the country. So as the graphs itself says, the deaths as well as the number of, the diseases, what we look at, the non-communicable diseases are increasing. That means the future of nursing in next 10 or 20 years, that means your nursing should be more towards non-communicable diseases. If you're specializing, it is always good to do more in the non-communicable diseases. Of course, communicable diseases are also important, but that is the burden of the disease. So nurses needs to be calculated based on the burden of disease what we have. If you bandwidth all the states into different categories, each state is equal to a big country in India, right? So the problems are state specific. So I think whatever micro planning we are doing, it should be state specific. Northeastern state problems are different from the southern states versus the EAG states, which are very, very focused. So I think we need to plan our nursing activities or the workforce, everything based on the burden of disease what we have in India. Again, data. This is one experience which we had with the Nursing Council in, Andhra Pradesh, erstwhile Andhra. Now it is divided into AP and Telangana. I know Rafat ma'am, and we also have the nursing registrar then who helped us too. This is the first time actually we started counting, because we don't know how many nurses are going out, what is the age of the nurse, where they are working. So this registration system, there was a lot of resistance initially. Okay. I'll take just 2 minutes and stop, ma'am. So the nursing registration, we also developed a curriculum management system in order to monitor the program. Basically, there are only 4 or 5 people in the registration, nursing registration, but in terms of monitoring, you have so many thousands of schools. So it is highly humanly impossible for them to monitor. So the Gujarat Nursing Council with us helped in developing the curriculum monitoring system. That is, you can do through system. There are certain things which you can monitor. Again, based on this, the learnings have gone to national level, and now we have a nurse registration tracking system. Chair, just 5 minutes exclusive.
I think you need to scale up just 1 or 2 minutes more.
Okay, technology in nursing, I don't want to say much, but there is a lot of, technological improvements. You have robotic nurses everywhere. But we also have to consider the voices in the field. If you see, I'll share the presentation with you. The voices in the field says that nurses are interested to work in the rural areas, unlike doctors. So definitely we need more nurses. Recommendations actually, kindly go through the FICCI report, which has actually come out in 2018, which talks about all the recommendations, how to improve nursing. There should be competency-based, you have to use technology, minimum essential skills are required. So these exclusively talks about nursing education improvement and also nursing practice, which are already self-explanatory on this slide. In terms of future of nursing, definitely we have to, would say that mainstream the health agenda into the framework of sustainable development and strengthening primary, secondary, and tertiary level care is very, very important. These are, again, 2017 recommendations, which we all know: standardization, revisiting the entry policies. Again, 2017, again, kindly go through the report, which has a lot of recommendations in strengthening the nursing education. Okay, and I'll just skip some of my slides, but so that I can finish off early. So definitely the nursing research is coming up, but these are all the areas which we thought are very, very, important for India. One is the clinical intervention, nursing education research, health workforce generation, numbers. We don't have numbers for anything. We don't have any dashboards. We just started. We don't know how many nurses in private sector, how many specialized nurses. We don't have any data. I think that is one of the major gap which is, hindering us to move forward. Telehealth intelligence, of course, artificial intelligence is coming up. And there's always questions that when can humanoid nurses can replace the robot. I would say as long as the AI, if a mother can be created by AI, I think then nursing, they can replace nursing. So I would say that. And then finally, definitely leaders. We are missing leaders, nursing leaders in the entire, whatever assessments we have done, we did not talk much about nursing leadership at all. We talked about more, research, we talked about education, we talked about career options. But the major part which we are missing is, I would say, the nursing leadership. And I think ANI is the superb, I would say, platform to take us forward. And then that is one of the major gaps in the entire assessments what we have done till now. So I'm really glad the founders and the current members, we have a lot to learn. Leaders are born. People say that leaders are born. No, I would say largely, even if the science also says that leaders are made. And I'm sure Annie would facilitate and help us, to build leaders in India. As one of the great persons says, if you don't give, if somebody does not give you a seat at the table, bring a folding chair. So I think we all have to carry a folding chair and go wherever we are, because nobody is going to invite us. It is our nursing, and I think we have to fight for it. I'm really glad and congratulate Annie for this wonderful forum. I'm really glad. I haven't heard about Annie. This is the first time, so I'm really would like to congratulate each one of you for this outstanding, I would say, conference. And thank you very much for the opportunity.
Thank you, Ms. Shirilata.
Apologies again for the extra time. Sorry.
No worries. Thank you. It was very enlightening what was past, what is present, and how is future taking up for nurses in the field of education, in practice, in technology, and above all of this, in nursing leadership. And you just heard, get a folding chair. I would go beyond. Try to find out who is defunct and occupy that chair. You need to go all out, make your way, make your inroads into the boardroom. It's a tough challenge, but nursing leaders have to, they know it all. They have to just use their authority and empower themselves and empower their teams. With that, I think we are a little behind time. Let's move on to our next speaker, Ms. Tangam Gomez, who needs no introductions. Tangam is a very dear nursing colleague, a friend. She's been driving Annie. It is her brainchild. All of us were pulled into it, at some willingly and some not so willingly, but everyone is really contributing to Annie. So these are all achievements of Tangam. And right now, Tangam wears multiple hats, from Signia to Annie and many more. She is very highly connected with our practicing nurses and the nursing leadership. And Tangam is talking on a topic which is not very conventional, which is coming out of the silos of nursing, unsiloing nursing. I don't know how many people understand here this word and what does it mean. So I will not take the thunder away. Let Ms. Tangam Gomez explain this and talk about how can we come out of these silos of nursing. Over to you, Tangam.
Take the mic from here itself. Thank you, Colonel Binu. And a very, very good morning to all of you. Good morning. How are you? Okay? How are you? Fine? I got some people. How are you? Fantastic. So, Colonel Binu said that she's not going to take the thunder away from me by talking about unsiloing. So let me start with a question. How many of you are sitting with your friends? Left, right, your friends are there. Please raise your hands. How nice, how nice. Nice meeting all of you. Please raise your hands for sitting with your friends. Okay, okay, okay. So when you go for tea breaks, lunch breaks, when you go hospital, how many of you go with your friends? How nice, how nice, how nice. Very nice. So that's exactly the same answer I expected from all of you. So I'll go back to 2001. When we were commissioning Fortis Hospital, Mohali, our CEO used to mandate that departments cannot sit their own department for lunch and tea. He will make rounds and say, Tankam, up, why you are sitting? What was he trying to do? He was only trying to unsilo. So we have this tendency, we are great by ourselves, do a lot of stuff within ourselves, but we stay within our cocoon. Silos are these big structures in which things are capacitated and kept there. So this unsiloing today, need some photos to get the cue from what I need to do. So friends, AV friends, I have my slides up. Now I have to speak impromptu. They, of course, they want me to talk, but I put some nice photos. So I'm trying to look for that. All right. So what happens? Yeah, thank you so much. So we give a clap to the AV peoples. They have got. I'm trying to unsilo myself from here to reach out to you and to the AV people also just by standing here. Can I go to the next slide, please? Oh, okay. Lovely. How many of you feel like this? This is not to talk about mental health. How many of you feel sometimes trapped in your role? Please raise your hands. I want to see response from the back people for the future of nursing. I'm not even looking at the front seat. They have done their bit. You are tomorrow. So many of us feel like that. Even today, sometimes like that. We feel trapped, or sometimes we trap ourselves because, as Binu said, the comfort zone. I'm very happy in my cage. Very happy. I know the dimensions. I go here, I go here, I go there, I go come here. I'm very happy. I will not move out. Feel like that. And in healthcare, yeah, oh, okay. Second pick. How many of you feel that all the departments, I'm sure that all of us are from hospitals. So, ma'am, that I had mentioned all about the entire data, numbers, and everything. Thank you so much. That set the contest. And how many of you feel that in hospitals, all the departments stand like this? Yes, no? I can see one hand saying yes, yes. How many of you feel that different departments, they are kind of standing like this, like silos? Do you agree or you don't agree? I need response. As I'll make you all stand up now. Say okay, say yes, go up. All right. So we all feel that we are in our silos. So let's see that unsiloing is important. True. The care that we give to our patients. Is it important? How many of you say yes? All of us say yes. Now, who is going to break down the silos? Thank you. So, Sandhya is doing like this. I think we all tend to know the right answers all the time. But when we get out of the auditorium, same hospital, same people, same attitude, same children, everything is same. And are we going to break down the same husband, same children? So my objective is very to understand the benefits of unsiloing. As I stand here, I'm going to only talk about our responsibility as nurses. What is it that we can do to break the silos? Very important. I had been with Fortis for 12 years. After that, I stepped out. It's a lot of pressure to get out of the silo. So nursing silos. So I'll start with nursing silos. Silos can be me, myself. I'm caught, my silo, very happy. I'm not talk to anyone. And I'll talk to my own people. The next silo within the nursing department. The nursing head, the quality head, the control nurse, the supervisors get together and decide what to be done with the young nurse. Do you like it? You like it? Or you would like to be part of it? You're afraid your boss is here. They don't know who is answering, so don't worry. You would like to be part of it. So that's a silo within the department itself. I am sure that a lot of esteemed leaders sitting here, they are doing their bit to unsilo by involving the frontliners decision making tables. But they are the warriors. They are on the battlefield. Are you on the battlefield? Hello? अरे यार इतना भी एनर्जी नहीं है. Hyderabad, no energy. You didn't get breakfast? Are you on the battlefield? I can't see what is written there. So I need to come back here. This is a definition of silo. An isolated grouping or department that functions apart from others, especially in a way seen as hindering, negating, and cooperating. Now, all these words you are aware, but unfortunately, when we silo, we don't get the full benefit of unsiloing ourselves. I really hope that by now, all of you are getting here with the word silos and unsiloing. So let's look at some of the, when are we in silos? When we are in silos, are we leading to fragmented care? I need quick answer so we can go, otherwise the dong will come, I'll get a heart attack. When we are in our silos, are we leading to fragmented care? Yes, okay, thank you. Are we leading to fragmented communications? Very good, now it's getting louder. This works. Are we also leading to fragmented solutions? Oh, that's very big, yes. This, all the leaders are listening, they are agreeing. We are going to be part of the solutions, not just become part of the problems. Yes? Okay, that's a big yes. All the leaders, take it up. Very good. Well done. Oh, sometimes it is running, sometimes it is not running. Like this or like this? Oh, that's better. So in all our journey, in our healthcare, patient is the only constant. All of us agree? Stories change, people change, bosses change. And though we don't have any choice to select our bosses or parents, can't do anything. Patient also we cannot select. But he is the only constant entire journey. And it makes business sense, makes medical sense, makes nursing sense. Break down the silos and come together. I've been doing leadership courses from well. I ask a question. Which are the departments you have the major problems? If I ask the same question here, I'll get the same answer. Pharmacy right on top. Housekeeping right on top. F&B right on top. So I try to explain to them why is it important that we stop saying pharmacy does not help. The problems are not getting solved. I have enough experience behind me to say that if I come out of my silo, walk down to the pharmacy, the HOD, ask him only one question. So I'll first a statement. I will tell, sir, your support, my department, so huge. Thank you so much. Support us to give the medicine right on. Thank you very much. Will smile. Already out of silo? Then I'll tell them, can we sit down for 5 minutes? Now I'll talk to him about delivery of medications with, as ma'am told, data. No atyachar there. You don't give me my medicine, my nurses are not able to give the medicine on time. How much shouting will I get? Doesn't work, my dear. Whether you are a bedside, you are a mid-level, top level, have data, say that what is the service that we would like to come out of that silo, shout to the other person. Want to hear more stories? We'll give you more stories. But today, before the bong comes, I have to stop. I'm really scared when that sound comes, so that I am trying to stop. I have lot of army friends. Everyone knows what does this. There is a word to it. I don't know whether it is in India. Chocolate rubbing. No. There is a word. I'm asking army leaders sitting here. There is actually a process. The process. I was very excited to read about this. Recently, I read, but this is from US. I'm sure maybe India also. I didn't get time to call one of you and ask. They are called battle buddies. All of you are asked now whether you are on the battleground. Said yes. So U.S. Army talks about putting buddies along with in nursing. Also, there are buddies, but only problem running the program is not the right. Here, thick and thin, the buddy will be backing them up just to be there. We need that kind of unsiloing within ourselves. The senior nurses wanting to step out, help the young nurses that I will guide you. Don't worry. I have my experience, so I'm going to share with you. We are struggling with maximum number of young nurses who are not prepared. Ladies are waiting to talk about it for a few minutes' time. So we need to come out of these silos and come up with really out of box things. And already been told what got us here, not get us further. So it is time for us to overcome the unwilling, have that passion. Passion is not within the auditorium. ANEICON is ignite your passion. Have some left. Finish the 2 days. When you go back, nothing changed. Okay, heart attack. All right. Before the next one comes, let me just go about talking about this. Okay. So just talk about unsiloing. In the unsiloing, that very big start practice starts with. I think this ANEICON, a great example of unsiloing. Go through the agenda, find varied professional, varied background, addition, showing that nurses are not talking about themselves. And ma'am told 70% of the workforce is nursing, 75%. And if we remain in silos, I think the healthcare is losing out, ma'am. Yes. So there is a request also, while the nurses are going to come out of their silos, the government and the regulational bodies, they need to unsilo and allow us to get as one, that we deliver and better results. Otherwise, we are talking about ourselves. We're doing some great. Ask these ladies who are running the department. They can talk for 1 week. Their pain. So we need to release the pain. Who will come and release the pain? We have to do something. Build it. And if you want to go fast, okay. 1 more minute, then I'm gone. Go alone. And if you want to go far, go with others. Then we have to. So it is a process. Thank you, slide. No, that go. Okay. So let's build it. Yes. Let's grow it. Let's sustain it. So when you go for tea breaks and lunch break, don't say diva, we will go for lunch. Go find another D or da. Make new friends and unsilo yourself and reap the benefits of best outcomes that you can get. Thank you very much, ladies and gentlemen, and young nurses. Thank you so much.
So saving on to time. Thank you, Ms. Sangam. And I think you will have a thoughtful weekend when you think of what you have to do to unsilo yourself and your teams at the hospital level. You just heard. You will have to go far. For that, you need to unsilo nursing as an individual, as teams in the hospitals. All right, moving on to the next speaker. We have Ms. Patricia Mary, the nursing superintendent from MS Ramaiah Hospital, Bangalore. And she's going to talk about a very futuristic topic, using artificial intelligence to transform nursing in India with DOSI. Over to you, Patricia. And all the other speakers have their time shortened because we have to get on with the next event. So you have 10 minutes to wrap up your topic, please.
Thank you very much, introduction. Morning, everybody, on and off there. I'm talking here about use AI to transform nursing in India. Okay, so you might think, and why nursing personnel and talking about DOSI? Since and we are using, and it's okay. We have benefited from DOSI, and so I wanted to transform that information to you so that in future, and you can also use and benefit from it. Healthcare scenario in India actually, and we need and 4.3 million more nurses by 2024 to meet and WHO norms. Okay, so according to the Global Health Security Index in 2021, India ranked 66th out of and 195 countries. And nurses are the one who shoulder the maximum burden during such emergencies. Okay, I hope and you agree to it. And issues commonly faced by us, here it's overworked due to the long shifts and patient safety concerns, untimely escalations, and high risk of acquired infections, inconsistent shift, and non-cooperative patients. So these are the main problem and which we face and in our nursing field, especially in clinical. So this is that burning issue which is there and it's okay in our field. So now additional for issues and faced as a nursing head is attrition issues. Okay, so here it is as per the like in statistics about 35% in 2020, and the training issues like and constant upskilling of junior staff who's changing the guidelines, and poor working conditions, infrastructure shortcomings, and delay in policy reforms, lack of recognition. A hierarchical work and environment leads to lack of recognition among nurses. Okay, so I hope this, and anyway, there is no explanation for it because and it's an everyday issues can be faced. The nurses workflow per patient actually with a like and about 11% of communicating with the patients and caregiver, and 14% in monitoring vitals, and medicine administration we spend about 9%, and charting communicating vitals are 25%. It's the main documentation. There's the NABH and everything, and it's when we come across documentation is more in our life. Indirect patient care and administrative activities about 12%. So you can see the time limits. Like the maximum and we spend for the documentation 9 to 12 minutes. Here on average of 39% of nurses time is spent on monitoring vitals, charting vitals, and communicating those vitals to the clinicians. So per patient, how much time and we take for the vitals? At least the minimum 5 minutes. Okay, so when we have and it's 30 patients in a ward, and we have to spend about and it's 45 minutes to 1 hour, and it's okay for the vitals monitoring. So the current protocol of patient care, monitoring of patients via spot checks every 4 to 6 hours, and manual calculation of early warning signs, that is a MUSE, how to identify patients deterioration early. So a lot of arrest which happens in the ward because of the lack of monitoring the patients, delayed intervention or transfer to ICU. So at the last moment, because and as per the MUSE, it is there already with us, but it is nobody checks it accurately and sincerely. They don't do it. The previous shift and whatever, and it's the score which is written, and they just write and go. They don't escalate to us. Okay. Because we have lot of newcomers in the field, and the seniors do not have time and for all this. Because they don't go and monitor also, because of delay in monitoring, lot of patients getting arrested in the ward, and very late delay shifting to the ICU, and the mortality happens over there. The time limit, if you see, okay, so intermittent spot check leading to the late recognition of deterioration, so that the patients are affected. So can we, and it's a compromise patient safety? No. So we have to give importance for this patient safety. So the deterioration of patients in the general wards, see the statistic stays like 90% are unmonitored and 73% are under who die in the hospital without and shifting them to the critical care unit. That means in the wards, the patients die and about 73%. How do we improve the patient care with the current challenges in infrastructure? So we have got a solution with a Dozy company. See, there is a sheet which is under the mattress, which you can see the sensor sheet. So that records our vibration, body vibrations, and the sounds like and heart and breath sounds and everything. And it is they have a technology which they have made it as, and it's to measure all our vital signs with a contactless. Okay, so this we have. See this is the and it's proudly we can say and it's in India. This is the first company which they have brought it to a contactless vital signs monitoring system. Okay. Okay, just 2 minutes. Yes. So here it is. We have started. See, here it is in the system, and it's actually we have started in Ramaya Hospital. Initially, we started in the August, and it's with the actually that time, and it's the BP was, and it's okay tied. The cuff was tied for the patients, and it's okay. The monitoring was happening. Now later, and they have and made it as and it's a non-contactless BP also. Okay, so we don't need to. This is not connected with the patients, but it is under the sensor is under the mattress. But it is okay. We can monitor everything in the nurses station, and it's we get all the values over there. In fact, and it's very important thing. It's we get an alert system. So they have made and based on Dozy early warning signs only based on these vitals: temperature, heart rate and respiration, saturation and BP alone. Okay. So the single screens, all the patients are and it's monitored. We use 60 beds and across 8 floors. And the alert system, actually they get an alarm in the nurses station first in the desktop level. Then to the supervisors and the ward in charges, we have given, they have given us the an app which we can monitor. We get an alert system. The managerial level, we have gotten system over there in the nursing superintendent office, even in the night, and it's okay. We can, the night supervisors can monitor, they can go and check, and it's immediately, and they can, we have shifted the patients to the
I'm
IC.
afraid you will have to wrap up.
Yes, ma'am. And even the doctors also is given the app, and it's okay. So we are monitoring it. So after starting it and our ICU shifting, it is increased, but the mortality it is decreased, and the code blue, and actually it is see after we started drastically you can see and it's how it is changed. So we have brought it down to 2 now. It is about 80% less, and even the staff nurses sorry ma'am.
Audience can connect with her when you catch up for tea.
Okay, so actually, and it's as a staff, and we are also happy, and its nurses are happy. In 15 minutes, and all 30 patients' vitals are monitored, and it is documented. Okay, so I'll be available. Even the Dozy company also available, and you can see it over there and outside. Okay, and then we will be able to brief you. At last, and it's I would like to say nobody can replace the care provided by the nurses. But AI will not replace the humans, but the humans with the power of AI will do the better than those without AI. Thank you.
Thank you, Patricia. I'm sorry for having up such an interesting presentation, which is going to save time and improve efficiency for nursing processes. And we request all of you to have a look at Dozy outside. Moving on to our last session, and my favorite topic and a burning topic for our country: bridging gaps between nursing education and nursing practice. And for that, we have 2 experts with us: Ms. Bindu George, CNO, AIG Hospital, Let's welcome her on the dais. She's from the practice side. And Dr. Rajni Peter, Professor and Principal, College of Nursing, AIMS. Can we have their CVs on the screen while they start speaking, please? Over to you, Bindu.
Morning, everyone. I shall just quickly rush through because Rajni has the education side. I thought after Rajni I would be speaking, but I am talking from the clinical side. That once a nurse graduates and come to clinicals, what is waiting them and what is the clinical side expecting of them? I'd just like to say this. This quote was there on the textbook of theories, nursing theories, and ever since I've not forgotten this. Theory without practice is empty, and practice without theory is blind, meaning dangerous. So, this is the topic. Now, all of us who are working in the clinical side, we are desperate looking for nurses who are extremely skilled or perfectly skilled and efficient and whose knowledge shall guide their practice. Right? We are also struggling to retain those nurses who are with all these attractive feathers. But are we reaching there? The front rows will be able to tell better probably. Yeah, we don't reach there. Yeah, we don't ever reach there. It's like a horizon for us. We think we will reach like next year. By the end of next year, we still see equal distance, right? So, what are our challenges? Getting quality education and then having a sound clinical practice or deciding or determining to anchor myself into a sound clinical practice and then learning abilities of the students or novice nurses. I hope no one will take this as an offense, but this is the experience that, learning abilities at times are really not allowing the novice nurses to absorb the challenges that is thrown by clinical nursing at these days. So there is one aspect there, and then enabling work environment. As leaders, are we able to give a pleasant or conducive work environment, learning environment for the novice nurse? So what can we do? I'm just quickly jumping into the topic. What can we do to integrate education to nursing practice? Encourage to apply the theory learned to practice. When I graduated with BSc nursing, people used to say, all that you're learning in the college is so. How many of you have heard this? Yeah, there we go. So I don't know from where that comes. And you know what? When you are a novice, really graduated and coming with, all your antennas tuned to absorb whatever you hear, this gets absorbed first because this is probably in the first week itself being. So as seniors or as people, nurses, professional nurses with experience, let's stop it right away because we are already past that time. We are beyond a point of no returns. So then it is going to be really bad for us. So let us understand and let's be clear that what we learn in the education system is what we practice at the patient side. And then once you come in as leaders, we have to custom design some training for these nurses these days. We have some of the custom designed such trainings, and then nurture local experts, meaning, me being the nursing head cannot take care of 1400 nurses who is working here. I need local experts in those areas. So we can't have just one nursing education department with 2 or 3 educators or instructors and then expect the whole of the nurses to be on one page or one platform, that knowledge and practice. And have academicians more involved in their patient care areas and vice versa. So academicians get more involved into clinical side and clinical staff gets into academic. Where it comes of benefit in terms of learning the skill. That's where clinical nurses can be of real good help. But then we need to have the theory backup step by step. Where is most damages observed? Mitigation skills. This is really a huge challenge for us. Patient presses the bell for the 5th time. Now I go to that patient like how? Don't think you are the only person I'm looking after. I have another 4 patients. This is some of our communications. Okay, I'm coming. Wait, I'm coming. Okay. So communication hugely missing. Infection prevention and control, a huge gap. We observe, and something that I have noticed is that this is not getting considered as a step in a procedure, and that's why this is getting bypassed, and then no one considers this as a step of a procedure. So it's forgotten and it's going off, and this is dangerous. Knowledge of drugs, yeah, and knowledge of disease itself and the course of treatment. So what can we do? Okay, there I go. OSCE and in-house videos that we can construct, live demonstrations, and then subscribe to training videos if you get some excellent ones. These are some of the training samples I wanted to show that we are following here in our programs. So we have started concentrating on the clinical education with regard to disease condition. Okay, I hope
Thank
that
you,
was
Bindu. You were so much on time, and the ambulance siren was really loud. So what we see here that to scale up and to do capacity building, to bridge the gap in practice, they've started and launched lot many programs to build knowledge about disease, about drugs, about the procedures itself. All of us will have to really work hard in this field. I think let's move on to the person who gives us insight, Professor Rajni, about the practice in education. So between the two, let's see how can we bring them together. There are good models in our country, but more have to come up in the future. Over to you, Rajni.
I've been given 5 minutes, so I think I just have to sleep.
We'll give you 7 minutes, but please wrap up in 7 minutes.
So I think it is more about what we all think in bridging the gap, and there is no perfect model where you can rely on that and you can bridge the gap. I think it is something which we have to constantly work on and make our own practical models of bridging. So we all acknowledge that the gap is real. Nursing education side always say that like we teach something, but the students go and practice something else following the staff which is there at the hospital. The staff, like often the complaint we hear are the staff are not focused on clinical judgment or critical thinking. There is this usual routine which is followed, one task after the other. The students have to follow what is being practiced. So what is being taught in the laboratories and in the classrooms cannot be followed at the clinical side. That's a nursing educator's perspective. And if you ask the nursing leaders in the practice side, they will say that the student who come and their competencies are not enough to work in the clinical environment. Their knowledge skills are lacking, the practical skills are lacking, the communication skills are lacking, and their compassion and the personal qualities of being a nurse is lacking. So I think the gap is evident from both sides, and everyone acknowledges that gap is there. And so one thing as an educationist, I would say that nursing education is not easy, and whatever we try to make the education, however we try to make it comprehensive, there is going to be holes in the comprehensive education. And because it is so diverse and complex, and we are going to prepare nurses to work in multiple areas, and so it's not possible for us to cover in 4 years all the possible experiences they are going to have in the clinical area. And so students also come with a lot of expectations. Like I come from the government background where I get very high quality meritorious students, and they are all coming jubilant, having cleared the national entrance exam with a lot of expectations about nursing, and I must say illusions. Like, so they have a different perspective altogether. So what is their views and their expectations are quite different from what is the reality. So to bring them, and so they experience this shock at the beginning of the education. So, and what we have to keep them motivated, keep them engaged, and finally make the transition from the student to practice smooth, and which is not an easy task. All of you will agree with me. And so I went through a lot of studies, and interestingly, the gap studies you find more from South Asian areas, Middle East areas. I wonder why not many studies are there in the West. So are they doing something differently? I have to explore it more. But this gap is very evident. Everybody is talking about this gap, and then how do we reduce the gap? And so a lot of the points are there which has come. These perspectives are coming from students, from the nurse leaders, academicians. They say that we all agree that the practical component, the practice training or the clinical learning is the most important thing which makes the student nurse capable to work at the bedside. And so the clinical preceptors or the student clinical instructors who go with the nursing students are not proficient enough to teach them. They are not familiar with the new equipments. They are not able to handle the emergencies. So they are not able to actually teach the students. And then ma'am talked about the silos. So we have this very clear silos of education and practice. So they don't communicate or collaborate with each other, and the student misses. And if you go to the clinical side, clinical preceptors, like again, there are deficiencies in their skill and in their proficiencies, and then they leave all about the critical thinking and clinical decision making in the colleges. And when we come into the practical area, we have all these assessment forms to fill and all these tasks to complete, the blood samples to be drawn, these consultations to be done, medications to be administered. So it is more like a task after the other. The comprehensive care concept of which is core to the nursing is lost somewhere. So whether the nurse preceptor is able to teach what is being taught, like what I wanted to, I'll skip to that. So what I wanted to say is that nursing is cognitive artfulness. Like you have to have this cognitive skills, and you have to be artful in making the nursing care, So ultimately it is our patients who are at the heart, and nursing is the compassionate, comprehensive care to the nurse, to our patients. So you just don't, your knowledge alone will not help, your skills alone will not help. Your compassion, your ability to communicate, how you are able to touch your patient. I mean emotionally and physically, like touch your patient makes the difference. So if a student nurse have to be transformed to a person like that, so just knowledge and skills are not enough. And the cognitive aspect has a lot of importance there. We are actually, nursing education, what are we trying to do? We are trying to help the students how to think. Like if you get a patient, how do you process all this information? How do you come to conclusions? How do you prioritize what has to be done? So this knowledge is very, very important. And our nursing assignments and how we design our clinical teaching is all for this. And so if the student is not given this base, just gaining skills alone won't help her. Ultimately, she will also miss the point of comprehensive, unique care to be given to our patients. So what happens is, with all these, the human touch part of the nursing will go missing. So this is what Indian Nursing Council has told are the 10 competencies, entry-level competencies the BSc Nursing, after graduation nursing, a student nurse should have. And we believe, the council believes that with these competencies, she would be able to work efficiently at the bedside. And so, you see, if we have to give these competencies, I think we cannot work in silos. The education and practice have to come together. And it is a reality that nursing educators from the academic side are not proficient enough in teaching the students at the bedside. And we all know that the clinical nurses know better than the nursing clinical instructors. So why don't we bring them in for teaching student nurses? Can we not have mechanisms where a large chunk of responsibility can be given to the clinical nurses? Now many people have tried various models, and some models work, some didn't work. And in Iran, they are talking about a clinical preceptorship program. It is something similar to our internship. Like in Indian Nursing Council syllabus, we have 6 months internship at 4th year, and but along with the internship, there is a clinical preceptor at the clinical side, whom the nursing student will shadow and work together for nursing and care of all the patients assigned to the staff, and she learn eventually. But somehow I read reports that this also did not work, because the clinical preceptors were not given enough importance in terms of recognition, in terms of salary, in terms of promotion policies, etc. So at every collegiate level, it is the responsibility of the teaching head to decide or to design programs or policies whereby the practice people can be brought together and make the education more comprehensive and student friendly. Student will appreciate if she is feeling as a member in the entire team, student nurse being part of the entire team and made responsible for patient care. So if we just stick on to just completion of assignments, sometimes even the student misses, and many times I feel that what is the basic concept of nursing, that concept is missing, not only from the student side, it is also missing at the clinical educator side, and also at the bedside nurses side. So if we can all agree on what nursing is, I think the silo also, it will be broken down and we can bridge the gap. So this was a study in Iran, and they are talking about these methods. If anybody is interested, I can, this is a qualitative study where many nurse leaders, both from practice side and education side, were asked. So they said there are 3 things we can do: develop and expand and make a context-based curriculum, and have interactive collaboration among nurses and the faculty, and design and implement localized clinical guidelines. So this is another model known as can care model. Here also you can see nurse learner is with a nurse expert, and the academic faculty is overseeing everybody, not interfering in the learning. So, and the faculty is also helping in mentoring the nurse expert. And so we have to have mutual and shared goals, and we should share our resources in terms of expertise and others, and we have to strengthen our education. In the first presentation, Madam has actually listed out various measures, which has been advised for strengthening nursing education. I think all of them matter, but what matters most is how we execute these measures.
Thank you.
So,
Thank you, Rajni.
Yeah, I'll wind up with
Let's
this.
do the care dance.
Let's
All
do the
right.
care dance. So what do I mean by care dance? Care to the patient is the most, and patient is the core person in whether it is education or practice. And what is the feature of dancing? In dancing, we all dance together. We are all parallel. There is no hierarchy there. So if we leave and forget about hierarchy and we are able to dance together as educator, as clinical instructor, as nurse mentor, I think we can, we can bridge the gap. Thank you very much.
Thank you, Rajni. So quickly in 4 minutes, if we can summarize the components you heard under the modernizing healthcare, hence modernizing nursing. We heard from Srilata about the future of nursing and what the context setting was, what is the budget given, what are the numbers, what are the shortages, what are the advancements, and what is it we have and how we are scaling up. You heard from Ms. Tangam about coming out from the silos and bridging barriers and moving in not just vertically but moving around yourself to adopt newer things and coming out of your comfort zones. From AI, a very good demo from Ms. Patricia, the DOSI demo, which is improving efficiencies and saving time, because we know that nursing is always short in numbers and the future also will struggle with numbers. Finding such efficient solutions will add to our efficient work process. And the last but not the least, you are bridging the gap between education and practice. every single conference I have been part, we have had this topic of bridging the gap. We have heard multiple solutions, but somehow in our country, we are still struggling bridging the gap because most hospitals do not have the nursing colleges and schools, and most colleges and schools do not have the hospitals. So they are two different verticals. There are, yes, exceptions which have got both. So here we need to come up with a healthy marriage or a healthy relationship where the education side and the practice side really collaborate. They are not competitors, but they collaborate because ultimate goal is confident nurses and efficient and good care to our patients for what we are meant for. Nursing is a combination of beautiful art and science. Art we can't forget even in these dynamic times, and the science we are catching up fast. So we have a great future nurses. Thank you panel members for a great insight opening day of the ANEICON. Congratulations.